Okay. So why there is a need for another target? This is important if we look into Improve IT trial. In Improve IT trial, the LDL cholesterol was brought down to around 53 milligram, and still about 32% of patients had events. In Fourier trial, the LDL cholesterol was reduced to around 30 milligram, and there was still cardiovascular event. Why these cardiovascular event with such a low and ultra low level of LDL cholesterol? So the question comes: is lipoprotein is responsible for this residual cardiovascular event? Why lipoprotein A? Because lipoprotein A is an LDL-like particle, and which we all know is proatherogenic, and it is attached with a disulfide bond with apoprotein A, and apoprotein A is prothrombotic. And both LDL particle and apoprotein, they carry oxidized phospholipid, which is known for its pro-inflammatory, pro-atherogenic, and pro-calcific effect. Remember, from particle to particle basis, lipoprotein particle is 6 times more atherogenic as compared to LDL particle. Why apoprotein A is carries a thrombotic property is because it resembles plasminogen. It shares Kringle 4, Kringle 5, and protease domain with plasminogen. And protease domain and Kringle 5 is responsible for the fibrinolytic activity of plasminogen. This is active in plasminogen protease domain, and it is inactive in plasminogen in lipoprotein A. So this means lipoprotein A doesn't contribute to the fibrinolytic activity. Rather, it competes with plasminogen for binding site on fibrin and endothelial cells, and it inhibits plasmin formation and prevents clot breakdown. And that is what LPA is known to cause atherothrombosis. Now let us look at Kringle 4. Kringle 4 is not in number, it is in multiple copies, and it is of 10 types. The Kringle 4 type 2 determines the size of lipoprotein A particle. If these repeat copies are less than 22, the LPA particle will be small, or it will be a small isoform, and if it is more than 22, it is going to be a large isoform or large LPA particle. You can see the different isoform of lipoprotein. Small isoforms are associated with high lipoprotein A blood level, whereas large apoform or large lipoprotein particle is associated with lower LPA concentration. 90% of lipoprotein A levels are genetically determined, but there are some conditions which can increase some amount of LPA and some can decrease it also. Now question comes, is it responsible for atherosclerosis? Because LDL particle is, we know that it has a causal relation with ASFD. Does lipoprotein also? Because it contains lipoprotein, LDL particle. Based upon epidemiological, genome-wide association and Mendelian randomization study has clearly shown that there is a positive relationship between LPA level and coronary artery disease or ASCVD. Those with population with high lipoprotein have 3 to 4 times more incidence of myocardial infarction, threefold increase in aortic stenosis, 1.6-fold increase in ischemic stroke, heart failure, and so on, as compared to those persons who are at a lower level of lipoprotein. Remember, there are some genetically, mediated lowering of lipoprotein A. It is said that if you reduce lipoprotein A by 1 standard deviation, it reduces calcific aortic stenosis by 37% and coronary artery disease by 29%. This is from UK Biobank, that in which the absolute lifetime risk of 25% at 7 milligram of lipoprotein, it jumped to 68% when the lipoprotein was 150 milligram. So there was absolute risk goes up by 48% above the baseline estimated risk. And it is not only with high risk patients, it was seen even in those with a 15% risk and even in low risk group of 5%. Now, if you don't go for LPA assessment, probably you will miss this increase in absolute risk and you will undertreat this patient. Therefore, it is very important for us to go for lipoprotein A assessment. In Bruneck study, there was a group of patients who were in intermediate risk group. And the question comes that how to treat these patients. But when lipoprotein levels were added to this Reynolds risk score by the criteria by which they were classified into moderate risk group, it was found that 40% of these patients were either goes to the low risk group or higher risk group. So they were reclassified into low risk group or a higher risk group. In Jupiter trial, it's a primary prevention trial with the achieved LDL cholesterol of 55 milligram, a very low level of LDL cholesterol in primary prevention trial. In this trial, it was found that those patients who had a higher baseline lipoprotein A, as compared to low baseline LPA, there was higher cardiovascular event in those with a high lipoprotein A. So that shows that lipoprotein independently, results into cardiovascular CV events. In a meta-analysis of secondary prevention trial, which included S4 trial, PROVITE trial, and MI trial, it was found that those patients who had a LPA at the higher quantile as compared to lower quantile, there was 40% higher cardiovascular event in those patients with the higher level of lipoprotein A. It's not only CV events which are increased. It makes some morphological changes in the plaque. There is in a study of about 191 patients which were treated with guidelines directed preventive strategy. What they found that low attenuation plaque volume, that is a rich lipid rich necrotic core, which is the worst part a plaque can have, it increased from 81 to 132 cubic millimeter. That shows it made the plaque more vulnerable for rupture. And in another study, it was found that as compared to less than 30 milligram, more than 30 milligram lipoprotein, there was increased prevalence of thin cap fibroatheroma. You know that if the cap thickness decreases to below 65 micron, it becomes a thin cap, and it is very vulnerable to cause acute coronary syndrome. So recently there is a publication by Nordesk et al. Which shows that it was a 10 years follow-up of patients with lipoprotein less than 50 milligram versus more than 50 milligram. What they found, which is about 125 nanomole versus more than or less than, they found that the basal percent atheroma volume was significantly higher in those patients who had lipoprotein more than 50 milligram or 125 nanomole. They had higher percentage of non-calcified plaque volume, and also they had a higher percentage of calcified plaque volume. And there was increased pericoronary adipose tissue. The ectopic fat deposit is not good. It is said to be, it increases the incidence of coronary artery disease. They found that there was increased pericoronary adipose tissue attenuation around both the right coronary and left LAD at the baseline and follow-up. They found there was additional information from this study that every doubling of lipoprotein A resulted in an additional 0.32% increment in percent atheroma volume for every 10 years of follow-up. That's extremely important, that you keep it on a higher range, there is going to be more vulnerable plaque. It is not that it increases cardiovascular event or it changes morphology of coronary plaque, but it increases the progression of mild or moderate aortic stenosis to severe aortic stenosis. As you can see, there is up to twofold higher hemodynamic progression rate on echo, and there is a higher need for aortic valve replacement in this group of patients. Mendelian randomization study estimated a 62% increase of aortic valve stenosis risk for each 10-fold lipoprotein. That's right. So you have seen that lipoprotein is a culprit for CV events. It is culprit for making vulnerable plaque, and it increases incidence of coronary calcified aortic stenosis. So these are the key points. So this means you have to lower lipoprotein A to decrease cardiovascular event and to stabilize the plaque and also to prevent its progression. Now question comes, how to lower lipoprotein A, and second important question, can CV events be reduced by lowering the lipoprotein A? How we are treating now and how we'll treat lipoprotein A in future. There are 4 methods by which we treat lipoprotein now. One is control all modifiable risk factors, LDL cholesterol optimization, aspirin, and lipoprotein apheresis. This is the present scenario, how you treat. But future will be gene silencing drugs, probably in a year or two it will be there, CETP inhibitor, and gene editing approach. Of course, that will take much longer time. Now, how the modifying traditional risk factor helps in reducing events? Again, going back to UK biobank studies, what they did, they classified patients into high risk group, middle risk group, and low risk group based upon traditional risk factor using JBS life risk estimating algorithm. Now, what they found that there was 68% absolute lifetime risk for CV events when the lipoprotein was 150 milligram. Now, in middle group, means when the traditional risk factors were reduced, so the patient came into the middle risk group, this from 68% risk came down to 41%. And in low risk group, it was just 14% with the same level of lipoprotein A of about 150 milligram. So what does it mean? By controlling traditional risk factor, either through primordial prevention or guidelines directed treatment, we can reduce absolute CV risk even if we can't reduce LPA levels. Even if the same level of lipoprotein A, aggressive control of a traditional risk factor is extremely important to reduce the risk which is going to result from elevated lipoprotein A. Now question comes LDL optimization. Remember, when we are talking of LDL cholesterol reduction in LPA, it is different from LDL cholesterol reduction for a particular ASCVD risk category. Now, for example, in ASCVD, what LA recommend is less than 50 milligram. So once you achieve this target of 50 milligram, then comes the role of further lowering of LDL cholesterol for higher lipoprotein A. This is based upon one study, which is an familial atherosclerosis treatment study. What they found in this study that those who had elevated lipoprotein A, 39% had CVD event if LDL cholesterol is lowered by less than 10%, and the events were only 9% when it was lowered by 10%. This is an additional LDL cholesterol lowering after you achieve the LDL cholesterol target for that particular disease. It's to have to be different. So if I achieve a target of less than 50 milligram of patient ASCVD, and if LPA is high, I will go for additional LDL cholesterol lowering to mitigate the consequences of elevated lipoprotein A. That's very important for us to understand. So there are a number of drugs which are available now. Dr. Sagar talked about that. Statin is one of the most important drug, very commonly used, reduces LDL by 20 to 50%, but some RCTs have shown that it increases LPA by about 11 to 20%. But subsequently, there are some big meta-analysis which shows that there is no such association between statin and increase in lipoprotein A plasma level. And another important observation was that in a meta-analysis that elevated lipoprotein A more strongly predicted CV events in statin-treated patients compared to those who were not on statin. Azitamide, commonly used drug, no effect or modest 7% reduction. Niacin reduces lipoprotein by 20 to 30%, but there is no cardiovascular outcome trials. There are a number of trials in which there was no benefit, rather there were more adverse effect. And bempedoic also, there is a modest reduction of 2.4% in clear harmony trial, not you can say negligible effect. Velucumab reduces LPA by around 27%. There were important points in this study that greater is the baseline lipoprotein A above the median, greater is the reduction in major adverse cardiovascular event. Like if the median was less 37 nanomole, those who had more than 37, there were 23% reduction in MACE as compared to 7% when their level was less than median. Another important fact which came out is that 25% in 25% of the patient with the highest lipoprotein A value, 39% of MACE benefit was attributed to the lipoprotein A lowering. Another fact which came out from this trial is that higher is the baseline, greater is the absolute risk reduction. Now, in Fourier trial, it was found that those patients who had an LPA of more than 50 milligram, there was 2.4% absolute risk reduction as compared to 1.4% when the LPA was less than 50 milligram. And in Odyssey trial, those who are on upper quartile, there was 3.7% absolute risk reduction versus 0.5% with lowest quartile. So that's very important for us. Inclisiran reduces LPA by 26 or 19%, 26% in Orient 10 trial, and 11 trials showed only 19%. Now coming to aspirin. Why aspirin? Because we know that LP is, because of apoprotein, it is a prothrombotic effect. So in a study, it has been found that those patients who had LPA more than 50 milligram without aspirin had significantly higher cardiovascular event as compared to those who had lipoprotein more than 50 with aspirin. So that is what. So aspirin should be given to the patients who have, even if there is no other risk factor, even if there is no ASCVD, should be given if the lipoprotein levels are higher. Like coming to lipoprotein apheresis, this is the only FDA approved treatment of lipoprotein to treatment of that. But during acute phase, it reduces lipoprotein A by about 50 to 85%. But if you take a time average, there is around 30% of lipoprotein A reduction. There is no RCTs at present that there is going to be benefit cardiovascular outcome trial, but there is an ongoing multi-select trial which is going to investigate the effect of LPA reduction by FRSS on cardiovascular outcome. But there was in 2013 there was a paper published, very interesting paper. They compared 2 years of pre-FRSS versus 2 years of post-FRSS, and they found that there was a significant reduction in myocardial infarction, PCI, and CABG post-FRSS as compared to pre-FRSS. That shows that there is a benefit in cardiovascular event reduction. Now coming to the whether pharmacologically we can treat, answer is yes. We have to just switch off the gene which is making this lipoprotein A. This can be switched off by two methods. One is antisense agents and second is a small interfering RNA. What is antisense agent? Is a single-stranded DNA which is complementary to the messenger RNA which produces LPA. Whereas small interfering RNA is a double-stranded RNA, and antisense portion of this drug is again complementary to the messenger RNA, which makes a lipoprotein A. They get into the hepatocytes. This antisense agents finds out the messenger RNA, binds with it, and destroys it. So there is no messenger RNA, so there will not be any production of lipoprotein A. That is how the level of lipoprotein comes down. There are 5 drugs in pipeline at present. One is pelacarsen. It is an antisense agent which is conjugated with galenic moiety for selective hepatic uptake. And the cardiovascular outcome result was expected this year, but we heard that it is postponed for a year. And this will tell us whether there is going to be benefit of in cardiovascular event when LPA is more than 70 milligram or 90 milligram patients with ASCVD. Opalsiran is a small interfering. Even we are expecting the cardiovascular outcome shortly in 2026. And the other two are Jarelsiran from phase 1 study shows LPA lowering up to 98% with single dose with sustained reduction over 5 months of more than 80%. Lepodisiran shows 97% LPA reduction from phase 1 trial of a single dose with a sustained reduction up to 1 year. We have an oral molecule, movalepilin, which shows about 65% reduction in a dose of 100 or more than 100 milligram. Oral CTP inhibitor, which is obicetrapib, which in a ROSE trial have shown that LPA comes down by 56% and LDL comes down by 51%. This is going to be a wonderful drug because it reduces both LDL and lipoprotein to almost same extent. And the final permanent treatment will be only by gene editing approach. You make the sequence which is responsible for increased lipoprotein A, correct it, and that will give a permanent solution. Now, what guidelines says about this thing? American guidelines says that relative indication for its measurement is family history of premature ASCVD. European guidelines says LPA measurement should be considered at least once in each adult person's lifetime to identify those with very high inherited lipoprotein A. Canadian Cardiovascular Society says LPA measurement once in a person's lifetime as a part of initial lipid screening. And NLA 2024 says LPA measurement in every adult at least once for cardiovascular risk assessment. LAI, we are different. And you will agree with me if something is genetically determined and what level you are going to achieve in 5 years will remain throughout. You know it's an atherogenic. India, we have a premature coronary artery disease. It is malignant atherosclerosis we suffer from. So what LAI says, you should screen for lipoprotein A at the first lipid profile screening of all subjects 18 years of age or at the age of 2 years if there is a family history of FH and premature ASCVD. This is what LAI recommends. What is normal? According to Americans and European, less than 30 and high is more than 50. What LAI says, less than 20 is normal, more than 50 is elevated, and 20 to 49 is a risk modifier. Now coming to the final slide, lipoprotein is among the strongest genetic risk factor for CVD and is also a strong predictor of a wide range of CVD events even in statin-treated patients. LP should be measured at the age 18 or earlier in every Indian subject for cardiovascular risk assessment rather than at least once in lifetime. There is no point if you measure lipoprotein A after the patient has suffered from myocardial infarction. If high at young age, you can make an aggressive effort for primordial prevention. So you can prevent hypertension, you can prevent diabetes, you can make his lifestyle in such a way that he doesn't suffer from risk factors. LPA level less than 20 is normal, 20 to 49 is a risk modifier, more than 50 is a high risk feature. Lipoprotein apheresis is the only FDA-approved therapy for reducing LPA. It is, of course, reserved for familial hypercholesterolemia. PCSK9 monoclonal antibody can reduce LPA by around 25%. Of course, we are going to have a newer drugs. So finally, LDL cholesterol still remains the primary target, non-HDL as a co-primary target, ApoB as a secondary target, and LPA still question mark because for now there is no cardiovascular outcome data on LPA lowering drugs, nor is there any information on how much to lower it if you want to reduce ASCVD event. Thank you very much for your kind attention.